Hey guys, welcome to post-conference. I know you guys all did your first med pass today, and I'm so proud of you, and I can't wait to hear about some of the drugs that you guys gave to patients. So I would love to hear each of you describe your drug. For example, today I helped a 57-year-old white male who came into the ER with heart block and bradycardia, and he needed atropine IV. So I hung that, and if you look on your drug sheet here, you know that we have to be real careful with atropine. Atropine inhibits the actions of acetylcholine at the postganglionic sites in the CNS, increasing heart rate. And it also crosses the blood-brain barrier, which is why it can be dangerous. So who can tell me what some of the adverse effects are of atropine?
Is it tachycardia, palpation, drowsiness, blurred vision, dry mouth, and impotence?
Yeah. We also have to watch out for pulmonary edema. So not only do we just have to be careful with atropine because it's atropine, but it also interacts with some other drugs like beta blockers, even antacids and potassium chloride, and also other anticholinergics. So what type of anticholinergic is atropine? Does anyone know?
Right here. It's a muscarinic antagonist.
Great.
Also, like scopolamine. Actually, I had a client that came into the ER. She was a 30-year-old, Caucasian, healthy, appeared alert and oriented ×4. And she came from a trip, and what happened, she had chief complaints of vomiting and dizziness. And I immediately thought, okay, she has motion sickness. So Dr. Don came in shortly after, and he diagnosed her with motion sickness as well, which made me really happy because it validated my findings. So after that, he also prescribed her 1.5 milligrams of the scopolamine. And it's to be run over a course every 3 days. And within those 3 days, it's about maybe 0.5 milligrams that is going to be delivered to the client. And it's on the post-oral site. And I also informed her of the mechanism of action, just letting her know that basically what it's going to do is block the messages in the brain that stimulates the nausea and the vomiting that she was having. And I also gave her a briefing of the side effects, which the most common is blurred vision, tachycardia, and dry mouth. So dry mouth is the most common, but tachycardia and blurred vision follows after. And as I was getting ready to update her MAR and the EMR record, she said, "Hey nurse, my father will love to travel too, but the thing is that he tends to have the same symptoms that she has, and he just does not want to do it at all. But she was wondering if he can also get scopolamine." And I told her that it's something that he needs to talk to or consult with his PCP about. And she did mention that he's about 68 years old, and he has glaucoma, and he's currently taking ecothiopate for his glaucoma. And I told her, yeah, it's contraindicated, so he needs to actually consult with his PCP for alternative measures.
So why is scopolamine contraindicated in patients who have glaucoma?
Oh, Austyn, it's contraindicated because it causes an increase in the intraocular pressure in the eye.
Yeah, I actually got to give a patient ecothiopate iodide today for the treatment of glaucoma. I cared for a 56-year-old Hispanic male who was in for the treatment of a diabetic ulcer. He had a history of type 2 diabetes and open-angle glaucoma. He was previously on pilocarpine for his glaucoma, but over the past few weeks they noticed his intraocular pressure was increasing, so they switched him over to the ecothiopate iodide to try and help decrease his intraocular pressure. I was able to assist him in his very first use of ecothiopate iodine. I taught him how to use aseptic technique to administer the drops. I also was able to educate him on the method of action of ecothiopate iodide. So in case you guys didn't know, it's an irreversible cholinesterase inhibitor. It suppresses both plasma and erythrocyte cholinesterase levels. The additional acetylcholine available at the muscarinic receptors of the ciliary muscle helps increase aqueous humor outflow. As we were talking as well, we also talked about his work on a farm and how he uses carbamate insecticides, which is also a cholinesterase inhibitor. So I had to explain to him that the combination of the medicine and being exposed to the pesticides he is can increase the effects of his medication. so that maybe he should try and limit his exposure to his pesticides. So then I also had explained to him, of course, any adverse reactions he might experience. So I told him about excessive sweating, muscle weakness, problems urinating, abdominal cramps, diarrhea, difficulty breathing, decrease in his blood pressure, or if he experienced what we would call floaters in his eye, that was just retinal detachment. And upon administration of his first dose of ecothiophy iodide, he did have some burning, a little bit of blurriness, but it subsided after 2 minutes, so he was fine. He had no other reactions. I went on and educated him on the doctor's orders of 1 drop per eye at night, but not to drive after administration because of decreased ability of the eye to accommodate, so it would be more dangerous for him to drive at night. But you were talking about atropine being a muscarinic antagonist, so do you think my patient would ever be able to take atropine?
Actually not, because atropine would actually reverse the effects of your medication.
Atropine actually also reverses the effects of the medication I gave today. I actually gave bethanechol, which atropine is used in the treatment of poisoning with bethanechol. My patient was a 30-year-old African-American female who was admitted to the hospital yesterday where she delivered her first child. She has a history of diabetes and voiding difficulties. After she delivered, she complained of pain in her bladder upon palpation, and she was unable to void for over 6 hours after the birth of her child.
Wow, so what were some of the primary nursing responsibilities you had to keep in mind when giving bethanechol?
Well, before I gave her the medication, I recorded the fluid intake and output, and I also checked her medical record for a history of peptic ulcer disease, urinary tract obstruction, intestinal obstruction, coronary insufficiency, hypotension, asthma, and hyperthyroidism, because these are all conditions that are contraindicated that bethanechol is contraindicated using. I also explained to my patient that bethanechol is a cholinergic agonist and that it binds reversibly to muscarinic receptors and actually enhances the transmission of acetylcholine. It treats urinary retention by acting specifically on the smooth muscle of the bladder. It can cause contraction of the detrusor, which increases bladder pressure, and relaxation of the trigone and sphincter, which is what actually allows the patient to void. I also ensured that my patient hadn't eaten within the last 2 hours because bethanechol can cause gastric upset. I explained to my patient that it can cause excessive salivation, sweating, urinary urgency, bradycardia, and hypotension, and that she should notify me immediately if any of those adverse side effects occur. Because this medication can be extremely fast-acting, I also made sure there was a bedpan nearby. After I gave her the medication, I monitored her blood pressure and her pulse rate, and I observed for any of the adverse side effects. I also monitored fluid intake and output to determine the efficacy of the medication.
Great. So do any of you guys know what some other medications are contraindicated for someone taking bethanechol?
Bethanechol can't be given with donepezil, which was the drug that my patient was on today, because they both increase acetylcholine at the synapse. They can, when used in combination, they can cause increased cholinergic adverse effects.
Awesome. So tell me more about your patient.
So my patient today was an 81-year-old Hispanic male who presented to the ER with a fall at home. He is alert and oriented to person, but not to place, time, or situation. He's been displaying symptoms of cognitive dysfunction, such as memory loss, inability to care for himself, frequently waking up at night, and inability to recognize dangerous situations. After a neurological consultation, Dr. Brain diagnosed him with Alzheimer's disease and prescribed donepezil via a 5 milligram disintegrating tablet orally. All of his vital signs are stable, and he remains calm as long as his wife is in the room with him.
But will donepezil cure Alzheimer's disease?
No, so donepezil doesn't actually cure Alzheimer's disease. It just mildly treats the symptoms of cognitive dysfunction in some of the patients. It works by reversibly inhibiting the enzyme anticholinesterase, which breaks down the neurotransmitter acetylcholine. Therefore, more acetylcholine is present at the cholinergic synapse, and the neurons that haven't been destroyed by the disease process have an increased amount of acetylcholine. So this can improve mental functioning in some patients. Since it's somewhat selective for anticholinesterase in the brain, it's the preferred agent for the treatment of Alzheimer's, but it still has some adverse effects, with the most common being nausea, headache, and diarrhea. It can also cause loss of appetite and vomiting. And as nurses, it's very important to perform regular cardiac assessments because donepezil can result in atrial fibrillation, AV block, bradycardia, hypertension, and syncope. Neurological assessments are also very important because other adverse effects include fatigue, abnormal dreams, depression, drowsiness, and insomnia. Urinary incontinence and frequent urination can also be adverse effects, so it's very important to take fall precautions because the patient may feel the need to get up quickly to go use the restroom.
Are there any other drugs that interact with donepezil besides botanical?
Yes, there are. There's succinylcholine, romaltine, ketoconazole, and quinidine. So all of these should either be not given with donepezil or should be monitored very closely.
I'm so proud of all of you. You guys all did a great job in your med pass today and reporting about all of your drugs. I heard great patient teaching. I heard adverse effects. I heard clinical uses and benefits. I heard mode of action. You guys are going to ace your pharmacology exam this week.
Yes.